Hi, this is Dr. Rudresh. Welcome to my YouTube channel, Medical Microbiology Guide. Please subscribe and press the bell button for more videos. In this session, we will discuss the protozoology and that the amoeba. Amoeba is a single-celled organism that constantly changes its shape. The name amoeba is derived from the Greek word amoeb, which means the change. We broadly classify the amoeba into intestinal amoeba and free-living amoeba. Again, the intestinal amoeba can be subdivided into pathogenic and non-pathogenic ones. The only pathogenic intestinal amoeba is Entamoeba histolytica. The non-pathogenic amoeba are Entamoeba dispar, Entamoeba meshkovsky, Entamoeba coli, and Entamoeba gingivalis. There are a lot of free-living amoeba in the environment, but I have listed only the three medically important free-living amoeba. They are Acanthamoeba species, Naegleria fowleri, Balamuthia mandilaris. So now I restrict my discussion on Entamoeba histolytica, and I am going to upload a new video for the free-living amoeba. The habitat of the Entamoeba histolytica is the mucosa and submucosa of the large intestine. Now let's see the morphology of the Entamoeba histolytica. Entamoeba histolytica, it has three stages: the trophozoite, precyst, and cyst. Now let's see the individual morphological forms. Trophozoite is an invasive form of parasite. This is passed only in the feces of patient with active dysentery. It measures around 8 to 30 micrometers. It has a cytoplasm which can be clearly differentiated into an ectoplasm and endoplasm. Ectoplasm is a clear structure and an endoplasm is a granular structure. The endoplasm contains food vacuoles and sometimes ingested RBCs. Ingested RBCs are the characteristic features of Entamoeba histolytica, but not the dispar. So, presence of the ingested RBCs indicate the invasive form of the infection and also the pathogenic Entamoeba. Nucleus is single, spherical, 4 to 6 micrometer in size, and it contains a central dot-like compact karyosome and surrounded by a fine peripheral chromatin. A pseudopodion is a long finger-like projections of the endoplasm through the ectoplasm. So this is a pseudopodion. This is an organ of locomotion. Because it lacks a particular organ, it's just an extension of cytoplasm. These organs are called as pseudopodions, are also called as false legs. Trophozoites are actively motile and their motility will be unidirectional, progressive and purposeful. That means they go with an intention of the feeding. Precyst is an intermediate stage between the trophozoite and cystic stage. It is oval with blunt pseudopodia. Cyst is the infective stage of the parasite. This is found in the forum stools. So you can see this is a quadrinucleated cyst. It is spherical in shape, measures around 10 to 20 micrometers in size. This is covered with a smooth chitinous shell which makes it resistant to gastric acid and other adverse conditions. The nuclear structure of the cyst is same as that of the trophozoites. So it can be uninucleated If it is so, it has chromatid body and a large glycogen mass. It can be quadrinucleated, which is nothing but a mature cyst which is present only in the gut lumen, and this will never invade any intestinal wall as the trophozoite does. Now let's see the life cycle. The life cycle is simple and completed in single host. The infective form of the parasite is mature quadrinucleated cyst. Mode of transmission is most common route is fecal-oral route. Rarely sexual contact may transmit the Entamoeba histolytica infection, and very rare the vectors can transmit the amoeba. Humans get infected by the ingestion of mature cyst in contaminated food and water. The mature cyst reaches the stomach, where they resist the gastric acidity with the help of chitinous wall. Then later on they will be passed into the small intestine. In the small intestine, the enzymes like trypsin will hydrolyze or dissolve the chitinous shell to produce a quadrinucleated trophozoite. This trophozoite nucleus further divides and it produces 8 metacystic trophozoites. These metacystic trophozoites they become the mature trophozoites and they pass into the colon. So they will be carried by the peristaltic movement to the ileocecal region, and this is the region, that is the cecum is the region where the amoeba starts multiplying, and most commonly it produces the lesion. So they colonizes the mucosal surfaces as well as the crypts of the large intestine. The trophozoites, once they move to the distal colon, because of food deprivation, overcrowding, desiccation and accumulation of waste products, they start encysting into the cyst forms. So these cyst forms are released in the excreta, and the excreta will get mixed with the food or the water, and if it is the contaminated water and the food, if it is ingested by another human being, the life cycle will continue. Now let's see the virulence factors of Entamoeba histolytica. Trophozoites, they play a major role in the pathogenesis of intestinal as well as extra-intestinal amoebiasis. Amoebic lectin antigen is present on the trophozoites of pathogenic Entamoeba histolytica. A similar type of lectin antigen can also be produced by Entamoeba dispar. This lectin antigen is a 260 kilodalton surface protein that consists of 170 and 35 kilodalton subunits. The 170 kilodalton protein mediates the adhesion, whereas 35 kilodalton protein along with adhesion it brings up the cytotoxicity. Because this is a lectin protein, it cannot activate the alternate complement pathway, hence it resists the complement activation. There are some other proteins like amoebic pore forming protein, cystine proteinases, so they can degrade the secretory IgA and the immunoglobulin G. The hydrolytic enzymes like RNases, neutral proteases and phosphatases can add to the virulence of the Entamoeba histolytica. Now let's see the pathogenesis. For the Entamoeba histolytica to produce the disease, first it has to colonize the intestine, especially the large intestine. Why large intestine is because the movement of the content will be slow in ileum and cecum. This slow transit will help the Entamoeba histolytica to colonize. Mere adhesion to the mucus of the large intestine will not produce the disease, but the Entamoeba histolytica, it has to go and attach to the epithelial cells to bring up the lesions. The lectin antigens of the Entamoeba histolytica, they attaches to N-acetyl galactosamine, which is present on the colonic mucosal cells, and it starts producing the other virulence factors to bring the lysis of the target cells. So once the mucosal layer is gone, the amoeba can invade the intestinal mucosa, and they can go to the extra-intestinal sites like the various tissues of the body, and they can also reach the bloodstream infection to metastasize into various organs of the body. The pathology of intestinal amoebiasis involves the invasion of the trophozoites into the colonic mucosa. So this invasion will produce characteristic ulcerative lesions and profuse bloody diarrhea, which is called as the amoebic dysentery. The amoebic ulcers are flask shaped. The flask shaped means they have a broad base and a narrow neck. These ulcers are round in shape and vary in size from pinhead to an inch size. They have ragged margins, and the ulcers are flask shaped with a broad base and a narrow neck. You can see the narrow neck and a broad base which look like a flask. The ulcers are round in shape and they vary in size from pinhead size to an size of inch. They have ragged edges and undermined margins, and they may be localized to ileocecal regions, or they can be generalized also. Most commonly, the lesions are seen in the cecum. They may be superficial or deep and are scattered with the intervening normal mucosa. The complications of intestinal amoebiasis are fulminant amoebic colitis, intestinal perforation and amoebic peritonitis, toxic megacolon and intussusception, amoebic appendicitis, perianal skin ulcers, chronic amoebiasis, and amoeboma. Amoeboma is nothing but amoebic granuloma. Let's see the pathology of extra-intestinal amoebiasis. So, amoebic liver abscess. Amoebic liver abscess can be single or multiple abscess. They are found most commonly on the posterior superior surface of the right lobe of the liver. So you can see a cut section showing the amoebic liver abscess on the posterior superior surface of the liver, the right lobe of liver. Amoebic liver abscess has three zones. An inner central zone which consists of the necrotic and lysed hepatocytes, but we cannot see any amoeba in this particular zone. An intermediate zone will be there where the degenerated liver cells, tissue cells, RBCs and occasionally trophozoites can be found. The outer zone is a layer of normal liver tissue invaded with the amoebic trophozoites. So this is a zone which is rich in trophozoites. That is why when we aspirate the amoebic liver abscess, we have to send the last portion of the abscess which contains the active trophozoites. If you take the first portion, which may be the central, the pus of the central zone, may not have sufficient amoeba that can be demonstrated in the lab. Liver abscess pus is thick chocolate brown in color and it is called as anchovy sauce pus. The complications of liver abscess are secondary bacterial infection. They can rupture into the pleural space to produce empyema, rupture into pericardium to produce pericarditis, rupture into the peritoneum to produce peritonitis. Also, they can rupture into esophagus and stomach. So, the extra-intestinal amoebiasis can occur in pleuropulmonary spaces. So, that's called as pleuropulmonary amoebiasis. So, this can be a direct extension from liver or from a metastatic foci. Cerebral amoebiasis, most of times it's a metastatic one. Cardiac amoebiasis, secondary to either the liver amoebiasis, that is liver abscess, or the metastatic one. Genitourinary amoebiasis and cutaneous amoebiasis. Among the clinical manifestation, intestinal amoebiasis, most of the times it can be asymptomatic, or if it is symptomatic, the non-dysenteric amoebic colitis can be there. So, in this one, the person will come with the clinical manifestations. Intestinal amoebiasis can present as non-dysenteric amoebic colitis. Here, a patient presents with intermittent diarrhea and abdominal pain. Acute amoebic dysentery is the most common form of the presentation, and this is usually acute in onset with abdominal pain, tender hepatomegaly, rectal tenesmus, and fever. The stool contains blood and mucus, which is a characteristic of dysentery, and the condition should be differentiated from the bacillary dysentery. Now, let's see the clinical manifestations of hepatic amoebiasis. It can cause non-suppurative amoebic hepatitis or amoebic liver abscess, which is the most common form of extra-intestinal amoebiasis, which occurs in around 10 to 50% of invasive amoebiasis. There will be association of high-grade fever and right abdominal pain. Let's study the epidemiology of Entamoeba histolytica. The reservoir of infection is infected humans. Usually, asymptomatic cyst passers are the main reservoirs. Source of infection is food and water contaminated with the human feces that consist of the mature quadrinucleated cyst. Mode of transmission most commonly through fecal-oral route. Rarely, vectors like flies and cockroaches can mechanically transfer the infection, and very rarely sexual contact may transmit the infection. To establish the diagnosis, we have to do the laboratory tests. Let's see what are the tests done to diagnose the amoebic infections. So we can do parasitic diagnosis, stool antigen detection, stool culture, serodiagnosis, and molecular diagnosis. The demonstration of the parasitic forms in the specimens will establish the diagnosis. So for intestinal amoebiasis, we have to collect the stool. We can also diagnose the intestinal amoebiasis by collecting the rectal exudates and rectal ulcers. Microscopy should be done within 1 to 2 hours of collection of the specimen. This is because the motility of the trophozoites will decrease after 1 to 2 hours, and also they may get destroyed. In case of delay, the sample can be preserved in polyvinyl alcohol. This will preserve the morphology of the trophozoite, which can be demonstrated by the staining techniques. The microscopy can be done by doing iodine or the saline mount. Usually, saline mount will be used for demonstration of the trophozoite and iodine mount for the demonstration of the cyst. The iodine will kill the trophozoite, hence we prefer to do saline mount for the demonstration of trophozoites. So, if you do take one specimen, then the sensitivity of detection of the parasitic forms is around 30 to 50%. So if we take 3 consecutive stool specimens, then the sensitivity will increase up to 90%. In cases where the parasitic load is very less, then we have to do stool concentration techniques. The formal ether concentration technique is used for the cyst, but no methods are available for the demonstration of the trophozoites. So we can do the staining for the stool smears. So permanent stainings like iron hematoxylin, trichrome stain and periodic acid stain can be used for staining the stool specimens. So we can demonstrate the internal structures of the trophozoite and cyst, which helps in the diagnosis of Entamoeba histolytica infection. The stool culture is used for diagnosis of chronic and asymptomatic intestinal infections. So we can also study the amoeba in detail. We can do the stool culture in two methods, that is, we can use the polygenic culture media or polygenic culture and the axenic culture. The polygenic cultures means we are going to use the bacteria like 4 to 5 bacteria along with the basal medium. So the medium which are used for polygenic cultures are National Institute of Health medium, Burke and Dr. Behlau egg serum based medium, Balamut's medium and Nelson's medium. The axenic culture using the Diamond's medium. Axenic culture means we are not going to use any bacteria in the culture medium already, because the culture medium will be already rich in the nutrients. The amoebic abscess can be diagnosed by the aspiration of the pus from the suspected liver abscess. So demonstration of the trophozoites in the aspirated liver pus will establish the diagnosis. The amoeba are abundant on the wall of the abscess, therefore they are best demonstrated in the last part of the pus which is aspirated. So we can do the light microscopy, which is done similarly to the stool specimens, or we can culture it on the NIH or Robinson's medium. The aspiration of the liver pus will be associated with some of the risk factors like bleeding, peritoneal spillage and secondary bacterial infections. We can do the antigen detection in the specimens both for the stool as well as the abscesses. We can detect the 170 kilodalton lectin antigen, which is specific for Entamoeba histolytica. So we use the principle of ELISA to detect this antigen in the specimens. Serodiagnosis can be done for invasive disease. We can demonstrate the amoebic antibodies by using indirect hemagglutination test or indirect fluorescent antibody test or ELISA. Molecular methods will help in the diagnosis of Entamoeba histolytica, as well as we can differentiate the Entamoeba histolytica from Entamoeba dispar. So many molecular methods are used for the diagnosis like DNA and RNA probes, PCR, riboprinting and isoenzyme patterns, which are called as zymodynes. The other modalities of diagnosis include the radiological diagnosis like X-ray abdomen, ultrasound abdomen, CT scan and MRI. The treatment of the amoebic infections can be done using various antiparasitic drugs. The luminal amoebocytes are the one which kills the parasites which resides only in the intestine. The luminal amoebocytes are diloxanate furoate, hydroxyquinol and paromomycin. The tissue amoebocytes, they are going to kill the amoebae from the tissue. So The drugs like metronidazole, tinidazole and emetic hydrochloride will kill the amoeba from all the tissue, whereas chloroquine will kill amoeba in liver only, and tetracycline and erythromycin will kill the amoeba from the intestinal wall only. The prevention of amoebic infections includes the individual prophylaxis, that is, improving the personal hygiene and safe drinking water, and community prophylaxis like sanitary disposal of the feces, prevention of the fecal contamination of water, and better management of the cases and carriers. Thank you for watching this video. Please subscribe and press the bell button for more videos.